If you watch closely, you can see the peristalsis. The hernia is large enough for the small intestine to slip out. This type of hernia is more serious, as the intestine could get trapped. So we reduce the hernia by pushing the intestine back into the abdominal cavity. The skin is pushed cranially, so we are not incising directly over the hernia and intestine. We have a small nick, which goes full thickness through the skin. To stay safe, we raise the skin and extend it with the scissors. You can immediately see the intestines below and the open muscle. We use a double grab technique with 2 pairs of forceps. This is where we grab the muscle away from the hernia. Then raise the muscle with these forceps, which allows us to safely grab the edge of the muscle. If we try and grab the muscle edge without doing this, we could accidentally catch the intestine and cause damage. Normally, in a hernia of this size, we would use a mesh. Unfortunately, charity funds aren't available for this, so we use a non-absorbable suture, which will eventually be capsulated. We could trim the edge of the muscle and use absorbable. However, this is a stray cat, so we have to avoid any risk of hernial breakdown. We place simple interrupted sutures, again reducing the risk of breakdown, when compared to a continuous pattern. The subcutaneous fat is obscuring the muscle edge, so I trim the fat away to give me better exposure of the muscle. Just to be sure, I add another suture. We now close the fat with absorbable suture, PGA in this case, to hide the not start deep superficial on one side, and then pass superficial deep on the other side, so the knot forms deep. First pass needs to be deep superficial, otherwise the knot is pulled up. I finish this layer with an aberdeen. Remember to keep the throws stacked tight, so no gaps are present. Tighten by feeding the lower part of the loop, and then expanding the loop with your fingers. Get into the habit of finishing aberdeens with a 2-pass re-security. Now hide the knot by taking a bite cranial to the knot, and exit caudally in the intradermal position, or whatever works for you. Now continue with the intradermals. These are always tricky when the skin is so thin. As always, burial of the knot is essential. Try to leave a small gap at the end. If the needle passes easy, the knot should follow and bury. Next to the knot, wiggle the needle until it passes easy. Lift the skin over the needle so it's not exiting too close to the knot. Pull the suture moderately, but using forceps, push the skin over the knot.